Hello, everyone. My name's Kathy Crane, and I'm a regional director for APDA. I want to welcome you to this exciting session entitled How Palliative Care Can Help People Living with PD. It's a challenging topic, but led by our very special guest, Dr. Andrew Esch. Dr. Esch is the Director of Palliative Care Program Development at the Center for Advance Palliative Care in New York. Dr. Esch speaks nationally on palliative care education and the growth and sustainability of palliative care programs. Dr. Esch, the floor is yours.
Thank you for having me. It's really great to be here, and I'm excited to be talking about palliative care and its application in people living with Parkinson's disease. So my name is Andy Esch. As the introduction said, I'm from the Center to Advance Palliative Care. We're based out of the Mount Sinai School of Medicine in New York. Been a palliative care physician for about 25 years. I bring sort of all that experience to you today, but we have a pretty, what looks like a packed agenda, but I'll be honest, I only have about 20 or 22 slides, I think. We'll move through those pretty quickly. And my hope is that I give you all a lot of time to ask or have your questions answered through the chat. So we're going to describe what palliative care is. We're going to talk about what the benefits are of palliative care. Describe how palliative care sort of intersects with people living with Parkinson's disease and, most importantly, their care partners or family caregivers. What you can expect from palliative care, questions you might want to ask your providers, and then there's some resources I'll share with you that if you want to learn some more about palliative care and what it can do for you as you live with your Parkinson's diagnosis. So we'll start with what is palliative care. Palliative care is basically specialized medical care for people living with a serious illness like Parkinson's. It focuses on the relief of symptoms and the stresses of serious illness. And really our whole goal is to improve the quality of life for the patient and the care partner or family. And this is done really through, we call it interprofessional care. The gold standard of palliative care teams is really a specialty trained team of different types of clinicians, usually made up of doctors, nurses, social work, chaplaincy. Sometimes there can be pharmacists or other things involved, but there's a core team that tries to address your needs. Because as you know, living with a serious illness, it's really rare for one practitioner to have all the expertise and all the sort of clinical acumen that's needed to help somebody live through something as complex and complicated as most serious illnesses are, and as our health system certainly is. So the other thing I just want to mention about palliative care is that it's based on need and not any sort of prognosis. So you don't have to be at a certain stage in your illness to need palliative care, or more importantly, to benefit from it. And we really do this alongside everything else your neurologists and other doctors are doing to try to treat the underlying problem. So whether it's curative treatment or life-prolonging treatment or just a treatment that's meant to manage symptoms, we're there as this extra layer of support to just try to get people through it with the highest quality of life as possible. We do know in palliative care that most people don't know what we do or confuse us with hospice care, and we're not that. I mean, we actually polled a bunch of patients about their understanding of palliative care. And what we found is that people really didn't know what palliative care was, or they did confuse it with hospice. But when we gave them a definition that I kind of showed on the previous slides, that it's specialty level care that goes on with your other treatment, and the goal is to improve quality of life. When we used that language and explained it to people, the majority, over 90% of people would consider palliative care for themselves or their family. Even more, almost 95% believe that patients should have access to this. And again, 3/4 of people thought it was important that patients and their families get education on palliative care, and that it's available along with curative treatments. So it's really sort of this extra layer of support add-on that can really help people live better with the diseases that they have. So why do it? Well, your quality of life is affected from the day of diagnosis going forward. Things change, and they change for the rest of the time you're going to be living with your serious illness. And so our focus is, how do we help you live with that illness the best that's possible? So how do we help you live with your Parkinson's as well as you can? There's going to be other things going on. These things very rarely happen in a vacuum, and that can be very complicating. When my dad was ill, he used to say, I don't need another doctor. I just need two doctors that would talk to each other. That's part of what palliative care does too. There's usually all these other things going on, might be other medical issues going on besides just your Parkinson's disease. It could be diabetes, high blood pressure, other things as well. So there's really kind of a conducting the orchestra aspect to this. We try to be that one communication hub that pulls things together for patients and families so that they can really understand how everything's fitting together and that people really are talking to each other. And we know through the research over the years that integrating palliative care along with disease-targeted or even curative treatment leads to better outcomes and a higher quality of life. These benefits of palliative care that lead to the better outcomes and better quality of life, it's really about just talking to the patient and finding out what matters to them and helping them to achieve what matters. It's also appropriate at any age and any stage. In fact, I would argue the earlier palliative care gets involved after diagnosis, the more impact they can have. It's like anything else, though. There may be times where you need a lot of input from your palliative care providers, and there may be times where things are going pretty smoothly and we're in the background a little bit. But we do this care alongside all your other treatments and really helps you just to try to understand what your goals are and match your treatment options to those goals. And again, it's provided by a team of specialists, usually from different disciplines, and it's really meant to be alongside all your other care. So there's special challenges in Parkinson's disease, and I don't know why this slide is not showing like it did. But what I will say, given that the text is not really showing up on this really just goes through a lot of the different symptoms that patients with Parkinson's disease experience. And so some of these are the movement-based symptoms, and really palliative care, there's some help we can do with that, but we're mostly going to be coordinating that the movement-related symptoms with the other docs treating your Parkinson's. But it's the non-movement symptoms that can be really impactful on people. Anxiety, depression, constipation, fatigue, apathy. You're living with all of these things that impact your quality of life, and palliative care can really help focus on those while your other specialists are focusing on the disease itself. And so that's a big part of what we try to do in palliative care is focus on those other symptoms that may be happening at the same time and not necessarily directly related to the Parkinson's disease. So, we know it can't be cured, but you can improve the symptoms, and palliative care can even go that next step for sort of the non-movement symptoms as well. Treating the symptoms and stress of diseases is just important as the disease itself. It's one of the things that, becomes more apparent the further I get into my career is that, how people live with what's going on is just as important as what they're living with. So we help by providing pain and symptom management. We provide emotional and psychological support. We try to coordinate your care between all the different clinicians that might be involved in your care. In many cases, we talk to patients about advanced care planning. That is basically goal setting. What's important to you? How do you see the future playing out? Who else do you want involved in decisions if there comes a time when you can't make decisions yourself? Those sort of things. We can't anticipate everything that happens for a person living with Parkinson's or any other serious illness, but we do know that there are certain things that we can discuss up front that help us navigate those decisions as they sort of hit us later on. So we may not know, everybody may not have the same experience with the illness, but we do know that having a healthcare surrogate or a proxy, someone to answer for you if you become incapacitated for some reason, little things like that can be set up in advance and are much easier to do in advance than they are in the moment. So what does palliative care appointment look like? Honestly, it really is a conversation. I spend most of my time listening. I usually start all of my interactions with patients and their families or their caregivers with how can I help? Because everybody's experience with illness is unique to them. Culture impacts it, caregiving support impacts it, other medical problems going on. So there's not really a cookie cutter approach to how to deal with a patient. So we usually in palliative care start any relationship with a patient and their caregivers with a family meeting, which is the time we're going to sit down, figure out what the symptoms are that are bothering you, what's important to you to accomplish with your life while you're living with Parkinson's, and addressing those symptoms and addressing those other needs that you have that impact your living with quality of life. So, this idea of a family meeting is really just like a listening session for us to get to know the patient and what's important to them. We oftentimes end up discussing different treatment options, even though we may not be the primary treating clinicians. We can answer a lot of questions around those. And again, above all, just exploring goals so we can help match treatment options to those goals. So there's always questions to ask your provider, and these next couple of slides have these questions on them. I won't go through every single one, but I think it's important to ask what can you expect from palliative care? Because not all teams are the same. Some have different specialists on them than others. It's not like every single palliative care team is going to look the same from site to site. So you might want to ask, what can you expect? Where will the care be provided? Do they do telehealth? Are you expected to be on site? Is there support if you're hospitalized? Those types of things. And really just anything that has been on your mind, but you've been too afraid to ask. I like to say palliative care is the place to ask it. I encourage my patients to bring in sheets of paper with things scribbled down. It's really helpful. We can only help it to the extent that we know what it's like living with the illness for you. So we really want you to come with these questions. Big one we get a lot is how do you communicate and work with all the other clinicians that are involved? And that's picking up the phone in a lot of cases. Sometimes you can communicate through the electronic medical record, but I would say that most of your palliative care providers pick up the phone and talk to your other specialists. It just seems to be the way it actually works best. So it's just a bunch of these questions you can ask from your palliative care providers on how they will go about communicating with you. People have different ways of doing that. But like I said, the bottom line is we want to know what's important to you, how we can help you achieve that while controlling your symptoms, and then communicating all that with your other providers as well. So most hospitals in this country have palliative care teams. The community, it's a little bit more hit or miss. It's getting a lot better. And there's a lot of people that can benefit from palliative care. So the place to start is just to ask any of the clinicians you're currently seeing if they know of the palliative care in your area and would be willing to make the referral so that you can get started with them. Just a note about caregiving, because it's become such a huge part of anyone living with a serious illness is the caregivers and the role that the caregivers play. Caregiving is exhausting. And I think if we don't acknowledge how exhausting it is and how much work they do, unpaid care that is provided in this country by caregivers is really, it's really humbling to think about that. We know that families and care partners get thrust into the position with little or no training, and it takes a tremendous toll on the caregiver themselves. They generally let their own physical health get put to the side. There's financial implications, there's social implications. A lot of time it's isolating, and there's psychological outcomes because people get so wrapped up in caregiving. And even some caregivers are caring for younger children and an older parent or somebody that is close to them. So, you know, trying to burn that candle at both ends is very exhausting. So caregiver burden is a term we use to describe this, and we know it's an issue. And it's one of the things in palliative care that the appointment is not just for the patient. We are always screening for how things are going for the caregiver as well. Because in our healthcare system, we don't really meet these challenges well. We're very disease focused and we don't focus on quality of life as much. And so I think, you know, palliative care is one of those attempts for us in healthcare to do better. We're great. If you break your leg or break your arm, we do a great job in orthopedics. We fix you up, we get you back on your feet, we get you out and going. Acute care is something that's done really well in this healthcare system in our country. What our system doesn't do well is somebody with a chronic ongoing illness with kind of an up and down trajectory where you're doing well sometimes, but then other times it kind of hits harder and you're having a more difficult time. So the issue is that a lot of us don't get trained to treat the symptoms and distress. In palliative care, we end up getting trained to do it. But in medical school, before I went into palliative care, there's not a lot of focus on pain management or symptom management, treating constipation, treating nausea. We don't get a lot of that. We don't get a lot of training on the distress or how to of an illness or how to communicate with patients. And so all of this is really within palliative care kind of normal for us, but most doctors don't get trained in it. So we can be sort of that safe place where people can get the support they're looking for when it comes to symptom management and distress management. And so we need to improve as a healthcare system in general, but I think we're on our way, and I think palliative care is a small part of that. And again, it's really the ultimate goal of all of this. I want my patients to live as long as possible. If there's treatment that helps them to live a longer life, I would like them to have that. But I want them to have that as long as it comes along with good functioning and quality of life, good coordinated and connected care. Like my dad's dream state. I want two doctors that talk to each other, not another doctor on top of the other 8 that I have. So we want to be that communication and coordination hub, and help support patients make informed decisions. Anybody living with a serious illness, Parkinson's or heart disease or cancer, whatever it may be, we ask our patients through their own autonomy to make decisions about their care. And oftentimes these are not clear-cut decisions. There's nuance. Do I do this new treatment? What are the side effects? Is it going to affect my quality of life in a way where it's not going to be worth it for the potential benefit? And these are conversations we have all the time in palliative care. And again, that's why it becomes so important to communicate with your other Parkinson's doctors too, because we want to make sure that we truly understand the treatments being proposed and what the pros and cons of everything would be. So it's really a big part of what we do is this communication and coordination of care. So I'm going to stop there, and I would love to just field questions for the time that we have remaining. And I think we have kind of a significant amount of time. I do have more slides with frequently asked questions that we get when I do these presentations to other groups, but I'm kind of hoping it will just sort of arise organically if we give that a shot. Kathy,
sure.
Okay.
Thank you, Dr. Esch.
Yeah.
The questions are coming through.
Oh, great.
So everyone keep asking. This is really an important topic, and you're right, misunderstood. The first question's from Teresa. She says, I tried to get palliative care to help manage my husband with Parkinson's care, but all I got was some in-home PT and OT. What should I have asked to help get help managing all the specialists who treat him?
Yeah, so it is one of the challenges in our field. Palliative care is one of the newest recognized subspecialties in medicine. So we are not as ingrained in the healthcare system as, say, cardiology or oncology or neurology is, right? So palliative care will look different from community to community. So part of the limitation is the palliative care you have access to in your community may not have a full team. It may be an effort to try to provide some extra layers of support, given whatever resources are available in that community. So that is part of a systemic problem where not everything looks the same. It's like that in every specialty in medicine, though, like rural care, sometimes, different urban areas have different access to care. So that's part of a limitation of the healthcare system in general. I think the most important thing to do is to really be, I don't want to say thoughtful because that's not the right word, but put some time in to thinking about what matters to you most, and develop a few questions for your clinicians about how the healthcare system can help you to achieve that. And it may be very, very simple. Like for my patients, a lot of times it's, I want to be able to have my symptoms controlled enough that I can stay on the medication that my doctor gave me to treat the illness. But I also would like to, go see a grandson or my nephew's, play or sporting event or whatever it may be. It can be real granular like that, because a statement like, I'd like to be able to go out and see a play or a sporting event, to me means, yes, I want to treat this disease. Yes, I want to do everything I can to treat the illness, but these other things are super important to me. So how can you manage my symptoms, or how can you arrange transportation for me if that's the issue, or whatever it may be, to make that possible. So I think the questions you might ask to get what you need are different for everybody, but you just kind of do a self-assessment of what's important to you and make sure you communicate that to your palliative care team. And hopefully they will work with whatever resources are available in the community to provide that.
Great. That's great. So from Linda, so is it the palliative care team that kind of serves as the conductor or coordinator of the patient's care? We have had some palliative care services for my mom after a hospital last year, but a lot of that has fallen by the wayside. So who's in charge, Dr. Esch?
Well, so I always defer to, so we're talking about Parkinson's today. So the neurologist or whoever it may be that's treating the Parkinson's disease, they're really going to drive the disease targeted treatments. The issue becomes a lot of the things that affect quality of life aren't necessarily disease generated issues. Like sometimes they're just anxiety from being diagnosed with an illness like this, or depression, or some uncontrolled pain symptoms, or other things that are going on. So what I try to do is I view this as a team effort, and then palliative care's role on the team is to be the conductor. We're not, or the coordinator, I should say. Coordinator is probably a better word, because I don't want to try to manage your Parkinson's, because I'm not the best qualified to do that. But what I am really good at is communication skills, because it's been part of my training. So I listen, I process, I try to figure out what's important to you by listening to you, and have, explaining back to you what I think I heard, and feeling very confident that I can be a spokesperson for you. And then with your other clinicians that are involved, I say, when I met with patient so-and-so, they said like this was super important to them. Can they do it while getting this treatment still? Do you have any objection to me using, a certain medication that may help them accomplish their goal? I don't think it interacts, but I just wanted to check with you to make sure you're good with it. It's that sort of coordinating care that I think palliative care should take ownership of, because we really have done the training to help us to do that. I feel like my palliative care training has empowered me to be able to talk to my colleagues in medicine, where I can talk to them medically, but it also has allowed me to learn how to translate that into language that patients and caregivers fully understand as well. Now, most patients and caregivers who have a serious illness get pretty savvy with medical terms, but not everybody does. And so I think that's a big role we play, is this coordinating care more so than conducting it.
That's wonderful. It leads into a question that Paul had. His doctors are not in one health system. So his neurologist is in a different system than some of his other doctors. Should he look for palliative care within the neurologist healthcare system? Does it make a difference? Who's where?
Yeah, good question. It shouldn't matter. In my career, I've seen patients from different systems. Like if I was employed by one health system, I would see patients from another. It shouldn't matter. The electronic medical records don't talk to each other. So it's some extra work on my end to pick up the phone and close those loops and coordinate the care. But that's part of what your palliative care team should be doing. So I think for you, for anyone seeking palliative care, I think convenience, is it close to home? Do they have, what you're looking for? Did you hit it off with the providers there? Do you feel connected? Do you feel like they're your ally? I think you go to where you feel the best or where it's most convenient. And then, like not every palliative care team is going to be the same, but for the most part, this coordinating care and communicating is part of what we do. And I think you wouldn't notice a difference being outside your current health system or within it.
Okay. How often do you meet with them?
Yeah, so I view what I do very much like dosing a medicine. Sometimes, if you're in pain, sometimes you need more pain medicine and other times you need less. So my whole feeling is I want people to, I want you to live your life. And so if we got things managed really well and things are going well, I'm not going to pull you in for a visit just so I can check in and feel better about what's happening. I would trust my patients to reach back out to us when they're, if they're having distress or if something's changed. So I view it like dosing anything else. There may be times where palliative care is super involved because there's a lot going on, maybe a progression of disease or a problem with a medication and you're having more side effects, or maybe you got COVID on top of your Parkinson's and you're really struggling with some things. Like there's a lot that can happen where we might get more involved, but when things are going well, we generally step into the background a little bit and let you live your life. So
great.
I'm not answering it directly because
okay.
It's kind of, I know it when I see it.
That's okay. Many of our viewers see their neurologist maybe twice a year.
Yeah.
Maybe less than that. So to know you're there is great. Lori asked, does Medicare cover palliative care?
Yeah, so if you're in a fee for service where you go to the doctor, you get a bill, it gets paid. Like we are just like any other medical subspecialty. So, we bill insurance like any other medical subspecialty, and then whatever co-pays there might be, patients and families are also responsible for those. So the short answer is yes. It's covered by all insurances. We're just viewed as another clinician that's billing.
Great. Okay, Holly asks, how do you suggest bringing this up with your neurologist? Is discussing palliative care, she's put /hospice, like waving the white flag?
I think if you bring up hospice, that may conjure some emotion in your neurologist that they may feel like, oh, is my patient giving up? I think so. There is a website called getpalliativecare.org. And this website actually has a lot of great resources. And one of the resources is things to ask your doctor or how to talk to your doctor about palliative care. And so I would encourage folks to go to Get Palliative Care and look for that document. It should be very easy to find. The other thing I would say is, rather than asking specifically for something, talk to them about how you're feeling or what your experience is. Hey, we've been doing this treatment and I can see how it's helping with some of my movements and other things, but like I really have been down, or I'm really fatigued, or I'm really apathetic. And, I was reading that palliative care might be able to help me while I'm doing treatment with you, maybe address some of these other things. Is that something that we could talk about? So focusing on what you're feeling rather than saying, hey, can I get palliative care? Because your clinicians might have bias too. Like your neurologist might hear palliative care and conflate it and confuse it with hospice too. And we don't want that to happen either. So, by saying how you're feeling what it's like living with the disease, and then bringing up that palliative care might be able to help is going to frame it in a different way that I think is not signaling that you're throwing in the towel, if that hopefully makes sense.
It's really looking for help, is what you're saying, right? So that's interesting. What are the triggers? That seems to be the hard part. What's the trigger to look for palliative care?
Yeah, so for most patients that end up coming to me, it's usually an unmanaged symptom. It's usually like pain or constipation or lack of sleep, or something just gets to a breaking point where there's a consult generated because they've tried all the sort of mainstream ways of dealing with this problematic symptom, and so they feel like palliative care can help. The other things is, if you don't feel like things are going as well as they could be, I think it's worth asking to talk with palliative care, because none of this stuff happens you don't get diagnosed with Parkinson's in a vacuum, right? Like, Parkinson's disease doesn't just happen. Like anything else that's been going on in your life, if you're an anxious person, if you maybe had depression, if you had diabetes, if you had anything else going on, that stuff doesn't stop happening just because you now have this new diagnosis as well. So really just being in tune with, is my life, going like I want it to be? Am I able to do the things that are important to me? And if the answer is no, or not as much as I would like, then I think palliative care is right. There's other obvious triggers like we use on the medical side: frequent emergency room visits, frequent after hours calls, like poorly managed symptoms. Those are things that as a clinician we might recognize, but I think for you, it's really about focusing about what's important to you, and are we as a healthcare team providing you the support you need to address those things.
Oh, that's great. Thank you. I know you talked about the getpalliativecare.org. Mark is asking for if there's a palliative care association.
So that's where I work. The Center to Advance Palliative Care is one national organization. There's the American Academy of Hospice and Palliative Medicine. There's a Hospice and Palliative Care Nurses Association. So there are national organizations for it. But for a patient and caregiver facing site, getpalliativecare.org is going to be your most comprehensive site. It gives great information about different diseases and how palliative care might help in those diseases. It gives, like I said, the directory of where you might be able to find palliative care in your community. It gives that list of how to talk to your doctor about palliative care. It gives a lot of that guidance. So for patients and caregivers, I think getpalliativecare.org is the place to go. I think if you're more interested in what's going on with this specialty on the clinical side or on the provider side, my organization, the Center to Advance Palliative Care, would be a spot you could look, or the American Academy of Hospice and Palliative Medicine.
Great. Very helpful. Thank you. So Susanna asks, what top 3 questions should a care partner ask when this process begins?
Yeah. Ask the palliative care provider. I would say, here's how my loved one is feeling, or the person I'm caring for is feeling. Like, this is what the experience has been like. I would just ask very specific questions. If fatigue's the issue, how do you propose you're going to address the fatigue? We've had a bunch of pain meds already and they didn't work. How are you going to approach pain? I would just be very direct. Mm-hmm. I like that the best when my patients come to me with direct questions. And a lot of time it's that type of phrasing, like, what are you going to do different than my 6 other doctors I've seen for this symptom have not been able to accomplish? And, sometimes those questions are really hard because a lot of my colleagues are really good and they've tried a lot of things. But the thing about palliative care that I think makes it so unique and so helpful is that a patient can come to me in pain and may have been on 6 different pain medications that didn't work. But when you sit and you listen to them and you know that that's the important thing that they want done. So how are you're asking me, how are you going to manage my loved one's pain? I would say, well, what have you tried? How did it work? What didn't work? What were the side effects? And then all of a sudden it comes out that maybe there was some trauma in the past, and this pain really isn't physical, but this is emotional pain. Like somebody may be feeling guilt, like they're being punished with their disease because of something that happened in the past. Like all this stuff bubbles to the surface, and you don't get there if you don't listen, and you certainly don't get there if you don't have people like social workers or chaplains or somebody on your team who can sort of pull this stuff out of patients. We say in palliative care that pain is not just physical pain. It's interpersonal relationships can cause pain if those are breaking down during illness. Existential crises, like you may not have, people can be spiritual, religious, both or neither. But I'll tell you, when you get faced with a serious illness, questions of why this happened to me, they don't want me to explain to them about oncogenes and genetics and things like that. What they want to know is, I tried to live my life as a good person. Why do I have to live with this now? And that's why we need chaplains and folks like that to help people work through that. So I'm being very long-winded. I think the 3 top questions you need to ask are the 3 things that are bothering the patient the most, and what are you going to do about it? And I would just be that direct, because that sort of direct questioning helps someone like me focus on, okay, like they've been through a lot. Like I'm not going to go back and tell them, hey, this medication didn't work before, but I'm going to magically dose it so that it will. Like, yeah. I need to go deeper than that.
Oh, right. Great advice. You talked about caregiver burnout. What if that's the trigger? I mean, that could be, right?
Yep. A lot of times it is. Breakdown in caregiving is a big reason that care falls apart in the home. It is the most challenging. I don't have a great answer for this because it's the most challenging aspect of it. Resources in the community to keep people at home and keep them living well at home are fairly scarce. So one of the things I do, like where, even though I work for the Center to Advance Palliative Care in New York City, my clinical practice is in Tampa, Florida. And like most palliative care teams, I mapped my community to know what resources are out there. So support groups for caregivers. Are there other community groups that are providing care for any caregiver from any different disease? Doesn't necessarily need to be Parkinson's. Are there church-related support groups? Are there organizations in the community that help with, a place where the patient can go during the day to give the patient with Parkinson's a break? Are there volunteer organizations? I think it's the palliative care team's role is to map what's available into the community and help match caregivers up with that. The other thing we do a lot of is training with caregivers, like training how to treat, say, it maybe not be a big issue in Parkinson's disease, but like a wound, some training about how to manage pain, like very simple stuff. Like when I give somebody a pain medication and the caregiver gives it to the patient and it's not working in 30 minutes and they don't know what to do. Well, if I had explained to them in the visit, like that pain medication is going to take an hour to reach its full capability in the bloodstream, the caregiver then is less distressed. They know I got to wait that full hour. Like just little tidbits of training like that ongoing help the caregiver to not feel as lost and overwhelmed. So training, I think, is part of it. I think linking to community resources is another part of it. And also just an acknowledgement that what they're going through sometimes is really uplifting for people, so they feel like they're not doing this in the shadows.
Yeah, we have the most fabulous caregivers in the Parkinson community. They carry the same optimism, but sometimes they feel like they have to do it all. So I'm assuming you're saying that that's a hard dialogue. Sometimes it's the person with Parkinson's disease who comes in and says, I'm worried about my partner. So just getting them a break, you do that as well? They go 24/7.
Yeah. I mean, that's a big part of it, is trying to get them some respite from it. And that a lot of times is dependent on what community resources exist.
Yeah, that makes sense. Okay. Claire says, I have a parent who continues to say he's fine, and is not communicating with my siblings, and I'm about planning for his Parkinson care. However, we will be the ones who will have to care for him when the time comes. Is there any advice on how to encourage planning and more open communication?
Yeah. There are tools that exist. There's validated tools that you can use. Four Wishes is coming. I'm drawing a blank on the names. I don't know why all of a sudden I blanked out. There are some formal tools, and they're on the getpalliativecare.org site that will help facilitate a conversation. But for the type of patient you're describing, my dad, for instance, is the same. Very stubborn, very German, very closed off and not wanting to talk about things. I would try, if you can get them to a step of, hey, we may not need to, you may not want to talk about all this, but one thing we do need to talk about is if for some reason you go outside and slip on ice and hit your head and can't answer for yourself, or we get in a car accident, or something we're not anticipating comes up and you're unable to speak for yourself, who from the people that love you and care for you would you want to be making those decisions for you? And could we talk just in some broad terms about some things that you might want or not want, just so that if we have to make those decisions, they're in your, they're honoring what you think is important. And if you take it into the abstract like that, it's sometimes helpful to do. At least that's been a good strategy for me with my family.
Great. I think we have time. We have less than 5 minutes left, so probably one question, maybe a tip or two if they only remember one thing from you. But Sue is asking, please discuss insurance reimbursement for palliative care, particularly commercial insurance, while they're still working to get this help.
Yeah. So like I said, we bill like any other clinician. The difference for us is we generally work in teams. And so I might submit a bill to your commercial insurance and I'll get paid the normal fee that a doctor gets paid for that visit. I have to somehow support all the other people on my team with that same amount of billing. It doesn't work. The math doesn't work. And I think that's probably what the question's getting at. So a lot of times palliative care teams are subsidized by hospitals or healthcare systems. Everywhere I've ever worked has had financial support from a bigger institution. Health systems doing it because they feel like it's just the right thing to do for patients and families. And so they underwrite the loss of revenue.
That's amazing.
Yeah. We cannot bill enough to make our services budget neutral. Like it doesn't work that way. But there's like the earlier slide I had up, like the majority of health systems have access to palliative care. So people have seen the value in it. So it's funded differently. So
great. Do you have one parting note? It's time for us to go, but you've been so helpful, Dr. Esch. This is fabulous.
Yeah, just ask, write things down and ask your clinicians. Like, don't be afraid to have the conversation. If you think palliative care can help, just ask for it, because it's really based on need and not prognosis. And so, if you get pushback about, well, you're not ready for that, just say, well, can I at least try it?
Great. Everyone hear that? Wonderful advice. Well, thank you so much for being with us today. If anyone has a question, there is a segment where you can go put it in. I hope we got to everybody's questions. Dr. Esch was just absolutely fabulous. We're going to take a quick break. Don't go very far. We'll be back in 10 minutes. And I hope that you will continue to join us. Thank you so much.